Yeah.
Am I good? Okay.
And I'm going to introduce Sarah.
Oh, yeah, sure.
Okay. So, Sarah Woolsey, who's been here since this morning, she is our medical director at HealthInsight. She's board certified in family medicine and is the clinical lead with the Utah Beacon Communities Project. She has a passion for empowering care providers around diabetes quality care. She's worked in quality improvement in outpatient settings for over 10 years with primary care and has 13 years of experience with underserved populations in Salt Lake City as a full-spectrum family doctor. Dr. Woolsey currently maintains an active in- and outpatient practice with the Community Health Centers of Salt Lake City. She is a graduate of the University of Illinois Chicago School of Medicine and completed her residency at the University of Utah. Sarah!
Thank you, Heidi. So thanks, Heidi. And thanks for your interest. Those of you who've been in this tract, we've talked a lot about this Beacon project. I'm going to talk about it from our clinical intervention point of view. And my attempt is to bring some sense of what are the strategies we used with clinical providers in the outpatient setting to be successful. So don't know exactly where it might apply with what you do, but it may. And we have an interesting story to tell. We have success and we have areas where we haven't had success. And like the other speakers, I want to talk about sort of the context that this is happening in. This, as you know, how many of you have identified an office or a primary care provider? Like you have a doctor's office that you recognize, you know, of some sort. You may not know all the pressures they're under. You will after this conference, but you may not know all the pressures and the change that are happening for them directly. And the Beacon Communities Projects really got right in the thick of that and has been asking a lot of them. And some have really risen to the challenge. And as a community, we've seen some significant improvements just jump-started with this project. So we'll share about that. And you know, in terms of the HealthInsight Circle, we kind of are involved in all those wings in this talk. You know, you'll see what we're trying to do at the very micro level of an office is this that we're trying to do as a macro level in the community. So we'll talk about that. My objectives are to describe our project at the primary care clinic delivery level, describe our strategies to altering care delivery and improving health. That's the ultimate goal. Discuss our biggest barriers and then share where we're at with next steps. Just to give that background, I feel like it's important to talk about. In 2001, the Institute of Medicine, which is a federally sponsored group of scientists and docs that come together to talk about healthcare, and there were local Utah people involved in this conversation, came out with Crossing the Quality Chasm, which you may or may not have heard of. But they worked on it for 5 or 6 years before they published it in 2001. And it was a call to action to transform our healthcare system. They talked about health IT and computer data as a platform for improving safety, patient-centeredness, communication, coordination, and lowering costs. Published in 2001, okay, call to action. 10 years later, we started our Beacon Communities Project. 10 years later, we are actually trying to implement and realize this. So I want you to, this has all been going on a long time. It's complex, it's slow, and a lot of moving parts have had to come together to make it real. I always have to bring in that George Bush signed the executive order in 2006. So Quality Chasm comes out in 2001. In 2004, he actually appointed a national coordinator for health information. So they began to say, this is a big deal for the US. And then an executive order in 2006 saying, we're going to promote quality and efficient delivery through the use of health IT. Oh, I have a pointer. And then make relevant information available to beneficiaries, patients, enrollees, and providers in a usable manner. Okay? So they're the next step. Why? Healthcare is too expensive. We have to find a new way to do this. We think technology is one part of that picture. And then too inefficient. This projects there are more of us. We are living longer with chronic disease. Those chronic diseases are requiring more healthcare. And you can see that our population is on the rise, and the amount of care at the current delivery system model is going to just skyrocket and overwhelm the system. So what can help? Well, we think IT may be potential. You also heard yesterday, if you were here with Mark, about the American Recovery and Reinvestment Act, a lot of money that Obama then put in, and part of that was high tech, subset of high tech, so $25 billion to stimulate computer health record incentives for hospitals, for doctors, for healthcare systems, vendor certifications, so have electronic health record vendors have certifications that require elements that we think are good for care. And then out of that was born the Beacon Communities Initiative. That's the rubber meet the road. Plug in that box, put it in the healthcare system, and actually prove you're improving an outcome. So that was the task of our Beacon group. And you can kind of see where we think this will go. Diabetes is a chronic condition. To move the trajectory of diabetes isn't easy in 10 years. We got 3. So we'll just show you what progress we've been able to make. And what's the problem we're looking to solve? Well, this is the ideal. We want to have these great people using these awesome electronic health records in these really streamlined ways. We have all this awesome data coming out that we can use. We're going to exchange that information at a community level. So you go to the doctor, they find out something about you. If you go to the ER the next day, now the ER can actually, through the information exchange, see, oh, look, that lab was abnormal at his doctor's office. That's why he showed up here to the emergency room. We're not going to repeat that lab. We're just going to treat him for what is important. Then we can actually, at a community level, analyze our data, have interventions that make the best use of our healthcare dollars and our community government dollars, understand our outcomes and reassess and continue that cycle. We think that would decrease healthcare costs and make health better. But what Beacon came into, is the current state. When electronic records were developed, they're filing cabinets, okay? They're paper-based systems. They're stuck into those workflows. They're not actually doing much but gumming it up. We get data, but it doesn't go any place that anyone can actually use it. Our health information exchange still to date is in an infant state where the amount of flow in and out is not yet at the level to really engage us and make an impact on health. To do any analysis, you know, a health insurance company, even who gets robust information about what care you get, they don't have any of your clinical lab data. They have to actually go do chart reviews, for example, to know what your diabetes lab levels are, or, for example, your BMI, your weight, okay, a big marker of how you're doing with your health. Let's say your insurance company, even if they have all the best interest in making your health better, they can't even get access to that unless you give it to them or they go do a chart audit. So just really labor intensive to get information and do any analysis. And then, so we don't do it as well as we could, and we're just looking through a small pinhole. So we started a Beacon Community Project in 2010. I like to show this slide just because it's a map and it's kind of cool. Doctors don't show maps a lot. Corey did, though. But I also feel very attached. So the Beacon Project, the clinics, every dot is one of our clinics. We had clinics across Tooele, Summit, and Salt Lake counties. And each of those clinics represents patients that are being cared for and patients who have diabetes in practices. And we developed a pretty big affinity for all of those practices and all those patients. And at this point, we're tracking over 22,000 of the patients across here. So I'll talk about that sort of data path. And then, you know, those represent 60-some clinics. And those providers and office teams that are really trying to implement their records, look at their populations, know them as a group and as individuals, and then move the needle on their care delivery. So these are our peeps, and they've worked really hard. And you can see that they're rural representation and then very urban representation. So we're working with a broad spectrum of folks. Who are our clinics? Just to give you a sense, and again, locate yourself in what kind of clinic you go to. You may not know, but think about it. So University of Utah, Intermountain, and Healthcare Association, HCA. So those are large corporate clinics. They have a fair amount of infrastructure for QI. They're integrated systems, so their doctors and their hospitals all are aligned in how they share money and resource. The 21 independent clinics were where HealthInsight really could impact, because we were going to align with the activities of these guys. Again, we're going to support and align with what they're doing, move them along in the trajectory they're on. But these guys didn't have really anything. Many of them have new electronic records. Imagine they're small business owners that are buying a $20,000 piece of equipment that's supposed to help them with their patients, and they don't necessarily know what to do. They know how to take care of patients. And there's some that are particularly savvy technologically, but many are not. And this is fun. We got to work with 19 different electronic health records that's just in 60 clinics, guys, 19 different ones. So the United States, with our super duper interest in entrepreneurship and the opportunity for anybody to put their thing out there, gave us this opportunity to figure out how to mine data out of 19 different electronic health records. And as we talk about the Health Information Exchange, guess what? 19 different ways to connect to the Health Information Exchange. So you can kind of see we're building the spider web. Few using electronic records well, that includes these guys. Intermountain's had electronic records a long time, but for certain parts of care, they aren't yet efficient. I will just disclose, Intermountain does not actually have a way to track patient foot exams. Okay, the complexity of the electronic health record, the complexity of their design, they can't actually track that. The University of Utah cannot track eye exams. So again, these large systems, very, very savvy, very, very good at what they do. I'm not disparaging their abilities, but the complexity of documenting these things that come from different kinds of data, they haven't cracked. So in our information, we don't track those two particular measures for those huge, large systems. And then we talked about the QI infrastructure and experience being varied. This is, medical speak, but I want to just talk about what is our challenge. We talked about improving health. So we're talking about having blood sugars better controlled in patients. That makes a difference. Having cholesterol be better controlled, having blood pressure be better controlled. That's the trifecta. If we can crack that, we significantly decrease heart attacks and strokes for patients. Then we get to kidney disease. Okay, #1 cause of dialysis in Utah and the US, diabetes. Retinal exams, we already talked about this morning. #1 cause of blindness in adults for Utah and the US, diabetes. And then foot screening, #1 cause of non-traumatic amputation in adults in Utah and the United States is diabetes. So #1, are our providers doing a baseline level of care? Do they know what they're doing? And can we make sure that's improved? Because this, at the end of the day, long term is going to be what's helping health. And then EHR use.
I'm reading that chart. Is that 10% improvement? Is that the goal, or 20%, or is that what we've achieved?
So our goal, sorry, these are our goals. Yep, these are our challenge, was to improve that at each site and then for us as a community. And there's a lot of statistical stuff we're talking about. Reduction in failure is what we were measured on at our large project level. But clinics, that's really hard to understand. So it's really just absolute improvement. And we'll show you that in the group. So the first thing you should ask is, what was the baseline? So we'll talk about that in a minute. OK, so that was our challenge. And just to show you here, I want to show you the results before I tell you some of the story. So for A1C control, so that's a control measure of how well sugar is controlled in the blood. This yellow line represents over 22,000 patients that we're able to get data on and track over time. And we do see a slight increase in that rate, so that's important to us. And then the independent clinics, that 21 group that's really the focus of our HealthInsight intervention, you can see they had a more significant increase. They had farther to go. And in the world of QI, right, what do we want to do? We want to reduce variation. So we think we're heading toward reducing variation in how our care is going to be delivered across these 3 counties through our interventions. And we're hoping the technology is going to help root that in place and that what we're learning will sustain over time. But we have seen improvement and more striking in some other areas. So in my opinion, what worked? What has worked, we're still evaluating our program. We ended September. So these are our strategies. So connection to the current climate, and I'll talk about that. That's that change environment providers are currently in. QI, basic QI, data has been extremely key. Engaging those office care teams, not doctors, but care teams, okay? Patient engagement, which Corey talked about earlier, it's key. The people who got it really got it. The ones who didn't are going to need to. And then I'll just put down here money, question mark. When I was working on this talk, I talked to Janet about, did our incentive work? We actually did a pay for performance with a small group of clinics. And you'll see, I don't know if it worked. You can see what you think. And then it did for some, yeah. And then methods. You'll see these scattered throughout. These are not anything special. Group learning sessions, coaching, peer-to-peer, having them especially talk, the ones that use the same electronic records. That was a useful peer-to-peer connection. Storytelling that we used throughout. Sometimes when we don't have data, stories motivate. And then advocacy at the level of us going to vendors saying, you have to teach us how to document better, or we're never going to be able to help these folks do better care. So a lot of advocacy happened in Beacon. Just our process at the clinic level. So you guys all know a leader, a champion's critical, especially a provider champion, an NP, a PA, or MD, or DO. So a clinician provider really makes a huge difference. If they're not there, we didn't see it work as well. But then designated QI team, having a HealthInsight coach like Janet and Heidi were some of our coaches, doing feedback sessions, doing smart aims, PDSA cycles, data, and then flowing around that for 3 years, basically. And then putting them in an environment of learning sessions, this state national political arena that I talked about in terms of healthcare reform changing, the health information exchange. Who knows what that is? Health information exchange from the talks. Have you gotten enough on that? Okay. Won't talk much about that. Healthscape website, using a portal where they could see their data, other Beacon sites, getting them together. So putting them in this community, we thought would also be a petri dish for improvement. So I'll go through each of the strategies and describe what I think what has made a difference. This is a slide I made. The first version of it was in 2010 when I started to work at HealthInsight, trying to understand everything that is happening to providers in this current climate. So I got this together, had a bunch of people look at it and say, okay, is this all the stuff that's happening? Providers, doctors working in offices are dealing with these numbers. At the Utah level, we're requiring public reporting of quality at the clinic level. There was a bill passed in 2009 about that. Are providers ready? Then accountable Medicaid, accountable care organization, that's heated up, and actually we're going to see implementation right about here. Our health insurance exchange that they spoke the first day, they're going to actually require quality reporting of providers. So quality reporting requirements, getting your house in order at a state level, at a federal level, okay? Tons of requirements to participate in meaningful use. So get paid to use your electronic record meaningfully in a way that the federal standards are included. Connect to a health information exchange. Report to Medicare certain quality data a certain way. Prescribe electronically a certain way. Because you'll see there's some carrots, and then out here, they start to be sticks. This slide in color has dollar signs that change color. We began to penalize providers late 2014, early 2015 for not complying with this. So go out and buy that really expensive record. Go figure out how to use it and see all your patients you need to. Go figure out how to report your quality care that you're doing. And if you don't, we're going to start reducing the payments to you. Okay? So not that it shouldn't be done, not that it's not a direction we need, but that trajectory is not very slow. Okay? So that's part of the environment. So we were coming into Beacon with that. Okay? So how do we attach in? How do we get their attention? How do we make this make sense? This is about meaningful use. So the Obama administration, part of high tech, is saying, let's get this country electrified. Let's start with primary care. Let's get them on records, and let's give them incentives to do so. I will go to the dollar signs down here. We were dealing with the Beacon clinics. They were trying to hit these targets. They could get either one. They can't get both. Could get either one of these, depending on their ability to attain certain measures. Plug in their box, and now use it usefully. It seems like it might be easy. It's not necessarily intuitive. And again, gumming up the usual workflow that we had. We've been using paper in medicine for thousands of years, we'll say. And to change overnight and make it make sense has been difficult. But guess what? They were super interested in attaining this, especially private docs who've invested, let's say, at least $20,000 in their system. So one of the things we did was connect. So this is Speak in Beacon. We said, how do you do Beacon and do meaningful use? The idea of meaningful use is to make care meaningful, right? So you put this data in the EHR, and then it improves patient care. There's a little disconnect there, but we tried to begin to make it make sense. How do you use the things that meaningful use, the federal requirements make you do, which is using an order set in a computer, so a list of check boxes that you've programmed in. How do you use that to actually impact care? Well, we said, make a favorites list of the things you always use when you take care of diabetes patients. So when you go to prescribe, the computer has already programmed in your favorite drugs, the ways that you prescribe them and the ways that you talk to patients about them. So it saves you time and saves you steps. and makes it easier for your staff to do your refills or to help you do things. So trying to connect meaningful use to actual patient care things providers were already doing. So one initiative we did. Another thing we did was say, okay, part of meaningful use, the feds want us to all exchange data meaningfully, okay? It's a good idea. On the practical level, it's slow. But we said, okay, so we're going to actually give monetary incentives as part of Beacon to get them connecting. So we offered that in their recruitment. We'll pay for your connection fees. And a lot of people were interested in that because it's a significant amount of money. We also said, hey, we're going to try to get you at the top of the queue. So as the electronic record in the clinic is connecting to the server that is our electronic health exchange, we want you to be first priority. Okay, so we were hoping that would work. And then we also planned technical assistance for rapid adoption and value. So providers say, I got to do this HIE thing anyway. HealthInsight's coming to me saying, they'll give me some money to do my connection. They'll give me some support to actually use this. It aligned and got them interested in our project. I will say, unfortunately, this has been one of our biggest disappointments in our project in terms of the usefulness, but it was an incentive and aligned for providers. Just financial incentives, the two that I already talked about, so aligning with those. And then later, we looked at the fact that doing QI as quickly and with the velocity we expected in our 3-year Beacon project, we were taking time, we were taking resource. Giving a monetary incentive would probably be a good way to continue this rapid pace. We're talking about moving eight measures, or we expected them to move 7 of 8 measures. That's a lot. That's a big bundle to move. And so we said, let's try a financial incentive. And then we thought it was fairly successful, so we did a second short one that's going on right now. So in a nutshell, the climate is complex for providers. How could we tap into what they're already doing, get their attention to participate? That's the strategies that we used. And if any of you are doing healthcare work, know that in the outpatient setting, this is a part of the environment, and the inpatient setting as well. And it's just going to get more and more complex and confusing as 2014 comes and more patients are insured, and we see this increased load of folks on top of everything we're doing. And then on my timeline, Meaningful Use 2 comes in, Meaningful Use 3 comes in. So there's no lack of continued change for the provider climate. Ongoing change and improvement processing using evidence. So as you know, docs like evidence-based stuff. If you're going to come in and tell them to do their practice differently, you're going to have to provide information that they value and that's valid. I would say 50-50, maybe even less than 50% of our clinics knew what QI or PDSA cycles were. So we started with basic education on quality improvement. In our initial learning session, we did a heavy amount of that. And then coaches like Janet went out monthly usually, and we're regularly working with the teams. And again, the ones that got it. The ones that didn't, haven't. PDSA worksheet for testing change. Some people are still scared of this in our project. Some people have adapted to it really well. We also looked at using evidence from our healthcare work. So this is a fault tree. So if you're not getting a particular outcome you want, why? What are the root causes? You'll see in here almost nothing on this. If a blood pressure is taken but the reading is inaccurate, there's nothing about health information technology here. There's nothing about computers. This is about how do we ensure that a blood pressure for a patient is accurately diagnosed. A big thing for providers is if you give them a number they don't believe, they won't do anything. They'll say, oh, come back, check it later. We need more information, right? Because they're not going to do an action. They're going to change a patient's clinical course unless they have good information. So one of the root causes of blood pressure poor control is that providers don't do anything when they see a high blood pressure. Why? Half the time they don't believe the number. The patient didn't take their pill, or the MA didn't take it right. So we worked with providers. Well, there's best practices. We can actually improve how our staff take our blood pressures. We can actually significantly improve the belief and trust between the care providers to actually impact the blood pressure numbers. So I'm going to go in and I'm going to treat Mrs. Smith when I see a high blood pressure because I know my staff took a great blood pressure, and that if it was inaccurate, they were going to come let me know that they had a concern. So just improving those kind of clinical touches made a difference. And again, I'm really into hypertension control, so I like these areas. But looking at, well, why are our patients not in control? We don't take it right. We don't write it down right. We don't diagnose it right. When we see a high number, we don't do anything as providers. Our patients don't understand the importance because they don't feel bad when they have a high blood pressure. And you know what? they need something, they can't get in to see us and to be supported. So if we look at all those things, there's really not technology anywhere. There are some technological solutions, but in a lot of cases, this is really just working with the clinics to improve things about clinical care that they needed. So we worked on that. And then early in our project, we were lucky enough to work with the health department on their diabetes practice recommendations. And these were a group of specialists, and we brought primary care folks together in a team to interpret all that literature and guideline stuff that's out there. And we put it into digestible formats that were easy to read, algorithms, templates, so using our best expertise from the university and Intermountain and nutritional experts, but putting it into a flowchart form so people could actually use it in a manner to train, to put it in their offices to use, to potentially program into their electronic health records. Some would work, some wouldn't. But making sure they had the best evidence with which to make their information. So we got to have that be part of our Beacon project. So QI, good information, evidence-based support for our clinics. The data thing. So data. My feeling about data was that people need goals. People need to believe the information they're getting, or they're going to have a hard time making any meaningful change, or that data is just going to be put on a stack and not used. And the second thing is the accurate, actionable patient data. So those two places were important in our interventions. And I think it was a data project. It was an IT project, so it seems like a huge focus, but I actually think our impact was very high with the data piece. So we'll talk about that. So when we first started with the clinics, most of them, we had no data, none. Like we couldn't even tell them their baseline. We had some clinics that were farther ahead, but even the clinics that were farther ahead and had more robust IT systems, the provider didn't know their numbers. They didn't know how they were doing. They knew how their clinic was doing or a broader, but it wasn't personal. So we spent quite a bit of time in the Beacon project looking for ways to get data from these 19 electronic health records and make it actionable. One of our first tries, this is one of the first, Janet's going to laugh when she sees this, one of the first things we would take out to patients, we made this up at HealthInsight. It was useless. So this was community-wide data, largely gotten from insurance and stuff. This was comparing them to the community with the stoplight version, so how you doing? This is our measures, and this is kind of their performance and their percentages. It wasn't very helpful. You can see we had 21,000 patients, and they had 646, but this did not impact any office that I know of, right? Yeah, and nobody really knew what it meant. And so, yeah, so I put on this one. This was very ineffective. This was our first try at showing data. And again, we were lucky to have some very skilled analysts help us move forward. This is what happened next. So this is what I call motivating data. So a very talented analyst with us was able to write a program to extract information from many of our electronic health records in these private settings and give them, those are points or months, right? So they get month to month. This is the clinic. How are they doing? They got their goal. So we wanted them to improve 10 or 20%. This is a screening, so it's 20%. And then they also could see that community benchmark. So we didn't take away the community benchmark because it did motivate some folks to say, oh, we're doing great compared to the community. Oh my gosh, we're not. But mostly they were interested in this stuff. Like, were they moving those lines? But really what they were interested in was here, okay? When we got it down to the level of the number of patients it's going to take you to get to goal. And what would they say? They'd say, who are they? I want to know. And so there was a combination of using our technical assistance and our computer record we could get those names for them, but we also wanted them to go get those names in their own record and to say, who are your patients with diabetes? Who are they? Why don't you know who they are? Why are they not coming in to get a basic finger prick that is standard of care in a year? Okay, so many patients should be seen twice a year. All we said was see them once. Okay, and we picked a threshold that wasn't the most strict threshold. We picked a medium threshold. So this is, I would say, unacceptable. If I was a doc in this system, I would be upset. And my system, we saw some of our numbers, and I was just horrified at what was happening. But this is what actually got people interested and said, HealthInsight, come help us do this. We want to improve this. So this really got people more engaged and wanted that. We want education on blood pressures, and we want education on how to start insulin for our patients, and we want education on how to change our workflow in our clinic to document better. A lot of this is poor documentation. What would happen is, the patient comes in, they do a test in the clinic. They don't stick it in a searchable field. It doesn't get recorded, okay? And when we go back to that graph of House Bill 128 Utah, you're going to be measured by your quality. You're going to start to become paid by how well you control certain aspects of your practice. If you can't document it right, game over. And nobody cares. They just want to know your rates. So we really got to that granular level of who are your diabetics, why aren't they coming in, why aren't you documenting in a way that you can then show people how great you're doing. So this is just a success where you can see, we worked with them for quite a while. This is probably them getting their patients in. When you first start to bring patients in that haven't been in, they're out of control. Their blood pressure is not at goal. But once we began to implement, we saw a significant improvement, kind of a plateau, and then they were able to hit. And you can see here, they hit their target, and then they maybe slipped a little bit. And what we want to see is that process going straight out where they really, really streamline and say, okay, every time our population can produce this effect. So this is called practice analytics, and this was a key in having these clinics get it. Now, you probably notice that we're doing it for them. They're not able to do it themselves. There is a significant failure in the electronic health record vendor system to produce actionable data for clinic level. We're big advocates that we use run charts, that there's month-to-month type data that can be pulled. And some of our clinics are learning how to do that. And there's a big market for third-party vendors to do this because they recognize the value. But unfortunately, the big investment our providers have put into electronic health records has yet to produce the kind of information in the kind of ways that's going to motivate them. And this is just from my electronic health record. We can do chronic care reports, and we're using HealthInsight's assistance to make our chronic care reports better and better and better. But off the shelf, our ECW, electronic health record, is not helping us do the data crunching that makes a difference in impacting our clinical workflow. So that's just a message from Beacon. And then this is, anybody recognize the Holy Grail? Meaning to meaningful use, right? So having these federal incentive programs cause electronic health record vendors to be awesome for patient care and provider activation, getting data into our health information exchanges seamlessly so that I see Mr. X, I diagnose him with a severe allergic reaction to penicillin, and when he goes to the ER unconscious, there's no way he will ever get penicillin, even when he can't talk to the ER physician, because he's given us permission to share his record, which is important, and that ER doc can go look easily, quickly, and make sure they don't ever administer penicillin to him while he's in the ER, right? So that's the holy grail we still have not attained, but we're moving forward and hoping that when those systems come, the providers we've impacted will be ready for that new data that comes. Care team engagement. So I just love this quote. This is from a book by Jim Conway on leading change. Quality improvement begins with love and vision, love of your patients, love of your work. If you begin with technique, improvement won't be achieved. And I don't know if that's true in your settings. It's definitely true in medicine, of course. This is one of our favorite clinics. This is the St. Mark's Family Healthcare Clinic. And just, they have really taken all of this work to heart. They were not our first group of clinics to hit their targets for their A1C controls and everything. They're on their way. They're almost there. But they have innovated. They have looked at their patients and said, why aren't we doing the best for them? And they've altered how their care teams work. They've added positions. This is Kelly. She used to be a medical assistant. Now she is a specially trained care coordinator. So for a low cost, Dr. Bernanke here can have his most high-risk patients that Corey talked about, the 80% of the dollars go to 20% of the patients. This clinic has actually looked at how do we target that 20% of the patients, and how do we give them the safety net they need. Most people are going to do okay, and most people with access are going to do okay, but there's this group that is just falling through the cracks, and they're going to the ER, and they're getting their feet amputated, and they're going blind, and they're going on dialysis. How can we change that trajectory with special kinds of primary care? And these guys have really taken it on. So kudos to them. Keys to engagement at our clinic level was strong leadership commitment, protecting them to have meetings, to have time to do this work. This is not just logical in the flow of a workday, right? You're slamming through 30 patients. So how do you protect them to do that? We talk about the presentation of actionable data, giving the clinic something they can use to communicate to their folks about what they're doing with their patients. The most impacting lists that people get would be report cards. Here's your report card. Here's how you're doing next to the doctor next to you. And suddenly people get really interested. Doctors are A students usually. Their teams get really passionate about being the best. And so if you can engage that fervor, it makes a difference. Trainings, spending time doing basic trainings on standards of care and making sure that people know processes. Local solutions, what works for one group doesn't work for the other. Willingness to try something new. Having, again, physicians, and a lot of people in healthcare are perfectionists or don't want to admit failure. Failure is not a useful thing in the culture, but when you're doing QI and you're trying, it's important. So get that message across and put people on your team that are okay to fail and to let them fail sometimes. And then the multidisciplinary team. Our most effective teams usually have a biller, a front desk person, a medical assistant, and sometimes the provider is minimal. They're actually not doing a ton. Because it's really that staff process that needs to be ingrained, and a strong staff leader will disseminate the protocols that are needed and support that provider. So they're suddenly not doing busy work, they're suddenly doing really important patient care. Just some examples of training. So we have this awesome electronic record, and when you put in a blood pressure that's abnormal, it lights up. And my pointer won't light up, there we go. But what do you do when it lights up? Right? What are the systems? What are the steps that your staff can take? For me, in my office, they see that. If the patient's having symptoms, they'll go get me, right? That's an emergency. But number two, they'll retake it. They'll make sure the patient's sitting quietly. They'll make sure a very proper blood pressure is taken, such that we're not getting just the fact that the guy ran in there from the bus, or that he's stressed out because his credit card didn't go through, which happens in my office for a amount. This is a real number that I can act on and we act on together. Or they'll say, why don't you come retake this? This makes no sense. Okay? But how do we put those steps in place? Not just MA enters it, walks out of the room, next patient. Okay? And then this patient's going to need to be seen later today or tomorrow. So they've already got the appointment scheduled when I walk in the room, because they know that I'm going to intervene in a different way when I see that kind of blood pressure. So that's the kind of thing we're talking about. Not just put the info in, but what do you do when it turns red? This is an example of, we talked about adherence. We find in my system, I work in a bicultural, bilingual system, patients are much more likely to answer this question honestly to my medical assistant who's a monolingual, or who's a bilingual native Spanish speaker, and who's culturally aligned with them. And they're going to say, no, I'm not taking it. I gave it to my mom in Mexico. I mean, it happens, right? I mailed my medicines to Mexico. So this stuff, how many days, that often you're more likely to get the real answer with your team. So empowering your team, developing protocols where they can ask these questions, and then you can go follow up on concerns and then make that difference. Anybody can do this with training, and your EMR can allow that to be documented and the right questions to be asked. And then protocols where, hey, somebody needs a foot exam. We've trained our staff to do the foot exams and trained for what is the abnormal stuff they need to look for, what are the duplicated things they need to do. There's a lot of medical care that can be done by a team, and it can be done offline with physician oversight, but the doc doesn't need to say do it. The EMR can tell them what to do, and it gets done. Another important part of team engagement is these learning sessions. It took them offline. So we had large learning sessions where we had panels of speakers from the clinic share their stories. We had best practices shared, like the Utah diabetes practice recommendations, and then just offline time where people sat with their peers from their teams and talked about what they could do next. That offline training time we thought was valuable. And then office trainings, lots of lunch and learns, lots of trainings that Janet and our colleagues did. One of the barriers to adequate glucose control in offices is that people are afraid to start insulin on their patients. And there's different reasons. Sometimes we're talking a clinic that has one doc, one medical assistant, and one office manager. Well, what does he or she need to do to make sure that while the patient's there, who needs the insulin, who's ready to learn, can learn? So could you develop that competency in-house, or do you contract with a diabetes educator or someone to come do that? Or do you have a pharmacist that you can call reliably and say, we're walking her over from the clinic to the hospital, please train her on insulin. So how do we take away barriers? Because a lot of times if we don't do something, inertia with providers is because they don't know how or they're not safe to do something. So empowering them to do that, okay? All right, last couple things. Patient engagement. So Corey talked about this. This is something that came late to many providers, right? They're just trying to figure out how to use the box, enter the data, get the stuff back, get the teams changed. Well, wait, we can't actually meet our beacon targets unless we've engaged our patients. Okay? It's really obvious on the outside, but when you're in the middle of it, You just think as a provider, you can do it all. If I just give them enough medicine and enough calls and enough this, but really how do we train the office systems and the providers to say, 5,000 minutes in the world, that's more important than my 15. How do I leverage that? This is just a story personally I like to tell. You know, this guy, he woke up one morning and said he needed to change. Okay, so how do we capture him in a system that maximizes that? This guy, you know, did a job that was out of town a lot, ate a lot of fast food, ate out, you know, really needed to change what he did with his diet. His wife is important. He decided he wanted to be around for his kids. This has nothing to do with the Beacon Project, 20% reduction of A1C, blood pressure control, or cholesterol. This is about what's important to this guy and tapping into it. And then Dr. Tran, another outstanding provider, like Dr. Masidas, like Dr. Bernanke and his team, who said, okay, you're ready. I'm going to do whatever it takes to teach you how to use your insulin and to have you learn how to do your checks and to be safe using it. And that guy got his numbers down within a very short amount of time, months, because he was interested and the clinic met him where he was at and tapped into what was important to him. So how do we get patients that he was ready? How do we move patients to that point of engagement? So things that we suggest and have been training on, health education, diabetes education, we know that these guys are experts in motivational change. Motivational interviewing. So the clinic I shared that has the care coordinator, we've actually trained most of their clinic, including front desk staff, on motivational interviewing. Motivational interviewing has been used in addiction science to find out really why is it that you want to quit drinking or smoking, or what are the barriers that you have to quitting drinking or quitting smoking or quitting a drug, and moving that into what is it about your care that's difficult, or what is most important to you that we get to. And so teaching them to have those kind of conversations, it's not that patients don't want to do the right thing. There's often a barrier in that. And when you really find out what it is, you can attack that. I mean, I can't even think of all the stories of things that we've discovered that you'd be surprised at the barrier and the times that, and Janet will talk about this next, so we'll wait for Janet, but the times where it was not your physician, it was somebody else who took the time and was trained to do this kind of interviewing, who found out what really would make the difference, okay, in care. Patient goal setting. This you're going to hear a lot more about in medicine, you know, patient-centered medicine, but really, what's a patient's goal? That guy that was being around for his kids, okay, tap into that energy. That's much more interesting than what his glucose is every day. Care coordination, like we talked about, the Care for Life texting. And then a few clinics adopted group visits. My system has adopted those. Patients come together. Their visits are actually sometimes like an hour and a half or 2 hours. They get a little time with the provider, but they get a lot of education. And then they have this time when we use a map where they actually talk about what they want to talk about their diabetes. So there's sort of pictures, and we say, hey, let's talk about eyes today. And then an educator will take them through a discussion, and somebody will say, oh yeah, my mom's blind from her diabetes. Or, hey, I had that retinal surgery to zap the bleeding in my eyes, and I'm fine. And you shouldn't be afraid to go get that done. So that peer support, in addition to education, makes for really valuable group visits, and it's cost effective. Okay, results. So I showed you the A1C control. We're happy to see some improvement, not like as stellar as we could, but I hoped that if this went out 5 years, we'd see more. We'll see. Our LDL, so our cholesterol control, very important. Again, you can kind of see that our independents have really, really improved significantly. We're very proud of that. And the whole community's seen, 4% improved. And then our blood pressure, same thing, steady improvements. This is all not easy to do, and not easy to do in a short time period. So again, not the stellar results we had imagined we could do, but with everything, we're glad the lines have gone up. Meaningful users, so our Beacon clinics, 98% have done the government testing, so they've been able to get that money, and they've been able to meaningfully use their computers, or they're in the pipeline to do it. Unfortunately, only a small number are connected into the health information exchange in what we call bidirectional way. So their information flows into the exchange, and they can get things back. So that I would consider a negative on our project. Incentives, so the money incentives we did, to date, 6 of our 12 pay-for-performance offices have received checks. It's only 50%. So does money work? Is it working? I'm not sure. Are the goals really just really hard to attain? Question there. We have our fast starts. We're hoping to do some short-term improvements with the clinics using our learning from these and see if we can get them there. And then 15 of 21 independents have received CHI connection fees, so that means that they have gotten their vendor to give them the bill for connecting to the CHI. But they're not connected. Barriers, so pretty typical in healthcare all over, I will say, and probably in lots of other areas. But bandwidth, getting attention for all the things that are happening. You know, you can see that we've engaged, if our 12 robust are pay for performance plus 3, you know, 7 of the 21 independent clinics have really not engaged. I would say one of them just independently was doing well, but the other ones just can't muster this. This is just too much with everything they did. And we did have a few, especially small clinics, drop out in the very beginning because they just couldn't do all of this. So just that's true. Meaningful data retrieval. Again, we keep wanting to turn off our practice analytics. We don't want to do it anymore. Yet the EMRs are not yet up to snuff. And we have these providers now hungry for the kind of information that's going to improve their care. And when the ACOs come a-calling, and when the shared savings projects are coming, they're going to be the ones that can demonstrate their quality. They don't want to lose the ability to do that through our programs or by having that continual improvement. So, you know, we're concerned about how that's going to go when Beacon ends. Barriers, identifying champions. Sometimes we lose champions. Sometimes champions would, you know, just not perform. That's such a huge part. And leadership buy-in, protecting these teams to do this work. Once they get it, it's not hard to sell, but initially some people just don't. You got to go see patients. You're not going to have time to make these changes. And then the last part, like I said, embrace of patient engagement. There's still quite a bit of paternalism in medicine. There's quite a bit of, I'll give you the drugs, I'll do the thing. Providers aren't paid. I don't know what Dr. Masidas is getting paid for with the stuff that he does. He knows it's the right thing to do. He knows it's improving outcomes. I don't think he can get paid for a fair amount of it. So I really, really applaud his effort to look at the root cause. I think in the system coming, we're going to be paid for outcomes. We're not going to be paid for the widgets that we see. But at this time, we have providers straddling that system. And the ones that get it have the hope for the future where if I can improve my population, it's the right thing to do, and the insurance companies will begin to reimburse me. But right now, that's not the case. Next steps for us is complete the success of 7 to 8 measures for the high performers. So those 6 that haven't quite made it, and those 3 fast starts, we're hoping they'll get there by September. The CHI connectivity and data sharing, we think this year may be a good year. There's a lot happening with getting information from major hospital systems into the CHI, so we're hoping to see use cases, and that remains to be seen. The legislature passed legislation last year that put all Medicaid patients and government PEHP employees automatically into the CHI, saying we think this is a valuable resource. So those patients can opt themselves out, but they're automatically put in versus all of us that have to sign a consent to get in at this point. So took away some of a roadblock, but not yet realizing the gains we'd like. So we're doing some experiments on that. Sustainability and increased spread of community data processes. So, you know, everybody's sort of interested in these benchmarks. Like we have a diabetes set of benchmarks for 3 counties, 22,000 patients. It's pretty cool. You know, it's been a collaborative project to get that information. That gives our community a benchmark. Where do we need to improve? But that doesn't exist for a lot of other disease states. These consortiums and collaboratives don't exist. We're in discussions with the health department. They're very interested in this. You know, how do we know how our community is doing? Our data systems, our infrastructure, and payment at this point is not aligned for that to happen easily, but we're going to continue to push forward because we've seen it happen with a lot of blood, sweat, and tears, but we've seen it happen in our project. And then patient-centered medical home. I just want to ask, how many people have ever heard that phrase? Janet, she's an expert. So patient-centered medical home is a movement that's come largely from pediatrics, but then has also been adapted. And the idea is that your primary care physician knows about you, helps coordinate care to specialists, and gets reimbursed for doing things like coordinating care. So having someone who calls you up to make sure you're able to get your prescriptions, or if you've come from the hospital, they get you right into clinic immediately. So it's sort of an expanded role of the primary care office saying if we can keep people attached to primary care offices and they do the things that patients need so they don't fall through the cracks, we're likely going to see less ER visits and hospitalizations, which is where the money is spent. You're from Corey's slides. So patient-centered medical home is sort of going across the country slowly, and the infrastructure that often offices need to provide that expanded care, that extra touch, that more time with certain patients, et cetera, at this point isn't reimbursed in most settings. So it's hard for providers to do it without the reimbursement. So we're going to keep advocating for it to keep meeting in the middle. And we're doing a pilot demonstration Janet's running with 6 clinics in the Wasatch Front to show, you know, can they do this? What will make a difference? And can we demonstrate some outcomes that will speak to insurers and to employers who pay for health care? Hey, this is the kind of clinics you want to hire, are the ones doing this kind of special care. So that's our next step. And Stephanie, I did it. I'm done. All right. So any questions for me? You can contact me. And then any questions? Yeah?
You touched on it briefly towards the end there, but
Yeah.
one of the focuses of Mark's discussion yesterday was the conflict between fee-for-service and all these
Outcomes.
improvements in healthcare. So I'd say about 90% of your presentation was it was focused on, hey, this is the right thing to do. I'm not saying that at the time.
Yeah.
Not at the
Yeah.
end, but hey, this is where we should go. This is where we are going. This is our goals and all that. But it's in conflict with the whole fee-for-service paradigm.
Darn it.
Well, but like in that first slide, you know, I mean, I don't know if you felt like Mark was giving a sense of the crystal ball, but we think that's where it's going. Medicaid ACO, the thing we can control in healthcare in the U.S. has said, Medicaid, here's some money. Go take care of people. Figure out how to do it efficiently in this ACO model. So this little sliver of our, 30% of our healthcare is going to that, has actually set benchmarks already through a very public process, if you're interested, on how they're going to pay in an ACO model for Medicaid patients. So we want to say to our providers, just what you're like, well, why do it? Well, because be ready. If Medicare demonstrations show that medical homes work, they're likely you're going to wake up one day and they're going to say, go be a medical home and we're going to pay you differently. And people will be scrambling for figuring out how to do that. So we think that readying our clinics to do this is the right thing to do. And I've sort of talked about, the pedigree, like be ready when the insurers come to talk to you about, can you take care of these difficult patients? Show us you can. And we can say, yes, here's what I've done to improve. Here's my processes. And we're encouraging them to really put in structures in place, that policies and procedures, things that demonstrate this is how we do it here. The St. Mark's Clinic, Medicare has begun to pay for transitions of care. So looking at Medicare patients saying, when are they most fragile? In the first 30 days of discharge from the hospital. They're likely to readmit. So primary care, we're going to actually pay you a little bit of money to go get those patients and keep them in a special nest, right, where you're making sure they're okay, they got their medications, that they have the services they need at home. We're going to pay you a little bit of money for that. And we're going to see if it reduces our rehospitalization rates. So St. Mark's has taken their care coordinator position. So she's a medical assistant. She's paid at a fairly low rate in the whole scheme of things. But she goes over to the hospital and she transitions those patients. And now their billing office is trying to figure out how to get paid from Medicare to support her position, right? So this office is trying to figure out, they got to keep their lights on and do the right thing for the patient and play the game. So that's an example of things are kind of shifting a little, and our idea is that our clinics will be ready. We hope. Is that hopeful?
And that's been, that's what we're here for. We're HealthInsight, trying to move from that fee-for-service. And it's happening in other parts of the United States. It's happening in Utah. Some of the clinics are already being reimbursed differently, how they get paid for their patient care. And we all know it's been, the fee-for-service is order more tests, you get paid more, right? And so now we need to start saying we're going to pay you for performance, and you have to demonstrate good outcomes. And I'm going to talk about this a little bit, but the way our system has evolved, the culture of healthcare is, the average visit is 12 to 15 minutes for a provider, and trying to squeeze excellent quality care into that amount of time. It's possible, but is it the best? And so Beacon is really getting people ready to start moving in those areas, because we're there. It's not even that it's coming, it's like we're there. So it's a huge culture shift. Huge. It's been it's exciting, but it's also kind of scary.
And then the nuts and bolts, the IT piece, the nuts and bolts. These insurance, they don't want to pay for no evidence for what you're doing, you know, and you can see the disconnect between what providers do, and they don't. I mean, until Beacon, a lot of them didn't know even how many diabetic patients they had. They never even were asked to look or looked, and now they know, and they know who the worst ones are, and, you know. So I think we're leading them along the primrose path. Good question. Yeah. Yeah.
Is PQRS physicians required to participate in that?
They will get penalized. So starting, based on your 2014 claims, you will begin to be penalized in Medicare reimbursements if you don't start doing it by 2014.
How many quality measures do they have to report?
Oh, God, you know what? I don't know. Do you know how many? There's like 100 some, but I think they only have 4, 10, 9, 10.
That's right.
Yeah.
They have to start doing that for meaningful use.
So you're eliciting some of the unfortunate parallel requirements that our federal government has. So meaningful use is one set of things, and then there's PQRS, which is Medicare, and they're sort of aligned, but not really.
I don't even think the physicians know they have to start doing that.
Yeah, we do a fair amount of technical assistance on that. If you would like, I have my card. If you would like to have us we can come do a presentation on it. And we're having a webinar on it. Are we having a webinar on PQRS in the summer? So we're having a webinar. Yeah, and then if you want, your providers can subscribe to our listserv that sends out information.
Yeah, and I thought it was interesting that you said some of the clinics initially dropped out of this project. Are they aware that they're going to be in Medicare space and whatnot?
A lot of them. Yeah, a lot of them are aware. I mean, I'm involved nationally with the Academy of Family Medicine, and you know, we've had there are very high level, you know, people in the leadership of the Academy of Family Medicine nationwide who've had to go out of business because their implementation of their electronic record and doing all this change, they couldn't do it. I mean, so I think they're kind of aware, but they're just trying to.
You know, denial's a funny thing.
Yeah.
There was a lot of people who really felt with the last election that Obama would be out of office and this would all go away. And we heard that from a lot of people. Meaningful use is going to go away. We've also heard if they actually make me do this, I'm retiring. I'm at the age, I got enough money, I don't need this grief.
Mm-hmm.
Yeah. So it's not, but how you're going to deal with the reality. Some people are like, I'm ready, I'm going to go for it, and the others are like, not happening.
Yeah.
And I was cubicle so we can hear some of the other project coordinators talking, and one of our meaningful use experts, I heard him fielding a call from a very, very angry physician who had gotten a letter from Medicare saying, you have been penalized 1% of your reimbursement because you haven't e-prescribed. You're not e-prescribed. And this poor guy is on the phone and he's trying to, and I said, I remember us telling her and telling her and telling her.
2 years ago. Yeah.
Okay, that was going to happen.
Yeah.
But they just, for whatever reason, it's like mortality with teenagers. They don't understand that it's real. And so, unfortunately, they get those letters and it becomes way too real.
They could even apply for an extension.
They will not. They said, she called the Medicare and they're like, nope, sorry. It's not like we haven't told you. This is real stuff, people.
And now also, defending providers, they're not good business people sometimes, and if they don't have an office manager, someone who's at the helm keeping an eye, you just don't have time to do it all. And so, we are a resource as, we're supporting to do that resource, but it's hard to keep it all in line. And, to do everything that's required takes a lot. And so, it's a complex world.
Especially our rural areas, that some of them were like, how could you not know about meaningful use? It's everywhere, It's on, anytime you get online and do anything medical, you have a meaningful use pop up from some EHR company. But they're like, oh, gosh, so they're just insulated too.
Yeah.
So they still don't know about a lot of it, and they don't want to know.
Yeah. No, Tom.
So, just help me connect the dots up.
Please.
So how does HealthInsight get reimbursed for the great work you're doing?
So the Beacon Committee was a competed grant. So we competed. There were only 17 grants in the U.S. So because of our, multi-stakeholder area, our success prior, we got that grant to support people with Medicare-related work, we're a designated quality improvement organization. So each state has a group that supports providers to do good Medicare quality. And so we do lots of projects in the community. And right now, we're a mouthpiece for a lot of these. Get up to speed on PQRS, know what's going on. You know, we have an expert in our office on that. You know, we're always trying to get the word out, and we do a lot of detailing. We go out and do presentations in different communities, and then do webinars and stuff. So we're the Regional Extension Center model, so that when they were trying to improve agricultural productivity, they set each, like Logan is our state agricultural extension. They've done that sort of model with QIOs, but also with electronic health records. So we are the Regional Extension Center to help people get their record, do it meaningfully, hit the meaningful use targets. So we provide technical assistance and federal funding largely. And then we partner with the health department, foundation applications. We do a lot of grant stuff. Yeah.
We're always educating the public, such as, I just happen to have this in my bag, and I'm gonna give it to the clinic. You know, it's just, how to start doing certain billings for care transitions. It's, you know, meaningful use stuff, you know, updates. So completely, you know, it's just constant education with clinics and what's coming and how you can, you know, survive these and thrive with these.
And then try things like Corey's project, like let's try texting and see if it impacts care, and if so, then make that available. And you know, we're partnering with nurses. You know, nurses can provide really excellent chronic care and do in a lot of settings. So we're partnered with the university and the Utah nurses to promote residency training for nurses and get them into rural areas and you know, help the workforce. So various projects. Our commitment is value and efficiency and safety and patient care. So you know, we're going to evolve with that. And right now it's a lot of outpatient interest because you can see it costs a lot less money to go to the doctor and be prevented of a bad thing than be in the hospital for a long time. And so how can we shift that and make our workforce ready to do it? And you can see we've hit some, but we have a lot of work to do. So thanks, you guys. All right.
Thanks, Sarah.
Yeah, thanks, Heidi. Thanks for the opportunity.